Welcome students. So today we are going to see about the management of extensively damaged teeth. This chapter deals with the strategies or the techniques and methods which are used for rehabilitation or restoration of teeth which are beyond repair or extensively broken. So here is a clinical picture of a molar and a premolar. So now let me know what is the treatment plan now. So most of you will be clueless. So let's see what is your treatment plan for these after this class. So this is the topic which we are dealing with to manage these type of teeth which have lost significant amount of tooth structure. Should we just go and cap them or put a crown for them immediately, or do we have the responsibility of reinforcing these teeth before rehabilitation or crowning them? So the central dogma or the central principle behind this is preserve what remains. Preservation of what remains is more important than replacement of what is lost. So this is the principle behind this entire presentation. And we have to try to preserve the teeth which are remaining, the tooth structure which is remaining, rather than replacement of what is missing. So first let us talk about extensively damaged teeth which are vital before going on to the non-vital teeth. So how will we replace or how are we going to rehabilitate the damaged vital teeth? So for this, what are the reasons? First, the teeth may be grossly decayed or damaged because of caries or because of a tooth fracture. So the first thing we have to see is the amount of tooth structure which is present and location of the destruction. And we also have to see the amount of tooth surface involved, which sometimes if it is going very deep, then we have to defer this treatment and go for an endodontic treatment and then rehabilitate the teeth. So the location of destruction for vital teeth can be classified as peripheral, which is occurring on the axial surfaces of the teeth, which does not go into the central part. So the central part is usually the pulp chamber and surrounding 1.5 mm of dentin surrounding the pulp chamber, or it can be a defect which is combined. So the key to preservation of this tooth is to preserve the core. The central core is the pulp and 1 to 1.5 mm of surrounding layer of dentin. So this must not be invaded in a vital teeth to preserve the vitality and the blood supply to the teeth. So no retentive features should extend far more than 1.5 mm into the cervical line or 1.5 mm from the central fossa. The caries removal, if it is going deep, so it should be filled with a base so that there is no damage to the pulp. So any preparation feature which is added for mechanical retention should be kept away from this core area. So the core must be always preserved. The next thing is the remaining dentin. So no wall of dentin should be reduced to a thickness than less than the height for its sake of retention. So for example, if we have a dentin which is 2 mm in height, so the height of the dentin and the thickness of the dentin have to be at least the same. So you should not reduce the height for the sake of retention or the thickness for the sake of retention and vice versa. So this is very important in case we are going for a full crown. So one must be very careful during the crown preparation. So what are the methods of gaining retention for this extensively damaged teeth? You can use box forms, which are shown here in the first picture, or grooves. So that this is very common in when we go for crowning these teeth which are very small or damaged, or to get more amount of retention, we can do pins or supragingival if the supragingival tooth has been destroyed. So we will see the box form. The box forms are more common in these crowns called 3/4 crowns or the 7/8 crowns in a molar. So these box form enhance the retention so that the crown which we give do not come out or they are not dislodged. The next is the grooves. Note that we should not place too many grooves. The grooves should be limited to maximum of 2 or 3 grooves. and it should be placed on the vertical walls. So make sure the grooves are on opposing surfaces. Minimum 1 mm deep should be the depth of the groove. Placing too many grooves can interfere with the seating of the crown. So sometimes to enhance or to rebuild the lost tooth structure, we place pins. These are pins which are carefully placed in a pinhole in the restoration. So they are always placed on sound dentine and not on the enamel. And always avoid perforation into the periodontal ligament. Do not encroach on the pulp, which is the central part. So the ideal location for placing the pin should be at least the dentine should be surrounded by, the pin should be surrounded by at least 0.5 mm of dentine. So the safest location are the line angles or corners of the tooth. So less desirable are the furcation areas or any area which is fragile or which can break. So this picture shows a extensively damaged tooth, that is the palatal aspect of the tooth or the lingual aspect of the tooth is broken. So here you can see the central core which is preserved, and the dentine is also preserved. But to replace the missing area, we are placing two pins. Note that the two pins are placed well on the sound dentine, at least 1.5 mm away from the external tooth surface or 1 mm away from the DEJ. Never place the pins on enamel because enamel is very brittle and it can fracture. So over this, we can do a core buildup and then proceed with a crown, or we can go for a composite buildup. Next, we go on to see the strategies for managing short clinical crowns or teeth with short clinical crowns, which are either vital or non-vital. So short clinical crowns, short abutments are found in, they are a result of unfavorable crown root ratio, maybe due to young teeth which are less erupted, or untreated teeth because of age factor, or because of constant bruxism or fractured teeth. So here now we have to understand what is a clinical crown and anatomical crown. The clinical crown refers to the crown which is seen above the gum line irrespective of the length of the root. So this is a short clinical crown. So the manageable strategy for this can be a crown lengthening. So we can do a orthodontic extrusion or a surgical extrusion or a combination of both. So the need for crown lengthening is to improve the aesthetics, to provide sufficient margin for structural durability, and to provide sufficient resistance and retention forms, and also to sometimes to correct the occlusal plane also. The crown lengthening, which can be done by surgical method. So this is a periodontal procedure and it should be performed at least 2 months prior to the placement of a crown or a restoration. So after crown lengthening, we give a temporary restoration so that the crown lengthening which has been done or the gingiva position which has been re-established is maintained. And this surgical procedure exposes the adequate crown to prevent the placement of the crown margin into the biological width. So this allows sufficient re-establishment of the biological width. So this picture shows a crown, here a premolar, which is at the level of gingiva. So after opening a flap, bone reduction or recontouring is done to expose the teeth. And this second picture is after healing, so which is roughly 2 months after healing. Now after this we can go for the permanent restoration. The next method of increasing the crown height is orthodontic extrusion, which is a non-surgical option. So these are the reasons for extrusion. It can be due to loss of teeth or fracture or caries or short clinical crowns, etc. So this picture shows you the method of orthodontic extrusion of a teeth. The teeth are basically slightly exposed and brackets are bonded onto the enamel of the teeth, and using elastics we slowly bring this teeth outwards. So here you see this picture of the teeth which have come out after complete orthodontic extrusion. So now you see sufficient amount of clinical crown which can be restored. So sometimes these teeth may require further endodontic treatment or further post and core procedures to gain more amount of retention. Now, how do we manage endodontically treated teeth or non-vital teeth? So restoration of endodontically treated teeth is dictated by the extent and the type of tooth. So here, post retained crown is commonly retained. So we call this as a post and core restoration. So there is no contraindication to use of a pulpless tooth as a part of a bridge. For example, you can also use that as a abutment for fixed partial dentures. So the post is defined as a segment of the restoration that is placed inside the root canal to aid in retention. So it can be fabricated from metal or non-metallic substances. So the post should be as long as possible. Usually we use only a parallel sided post, and the dimension of the post should be according to the root canal configuration. And we also have to include a ferrule, and sometimes we place anti-rotational grooves or keys. So the function of the post is to provide retention of the core. So the post-paste preparation is the process by which we remove the gutta percha inside this root canal treated teeth. Only apical gutta percha of 4 mm is left and the remaining gutta percha is removed. For this process, we use the piezo reamer. It starts from size 1 to 6, and depending on the diameter of the canal, we can use the appropriate size. So posts can be custom made posts, prefabricated posts, or metallic posts, or non-metallic posts. So we will see each one in detail. The post length is usually we keep a post length of 6 to 8 millimeter. Also, we should not extend it too much into the root so that there is a root fracture, possibility of root fracture. Always incorporation of a 1.5 to 2 millimeter natural tooth structure around this post. This tooth structure is called as the ferrule. It reinforces or enhances the retention of the crown and prevents further damage. So in this picture, this is the ferrule. You have the crown on top, you have the tooth, and a normal tooth structure of around 2 mm is seen as the ferrule. This can be much more clearly seen in this clinical picture. You see the core buildup on top and the natural tooth structure in the bottom near the gingiva. So prefabricated metal posts are these posts. Usually we do not use the threaded form because of the risk of fracture of the tooth. We also have prefabricated fiber posts like this. These are glued into the post base using a resin cement, and for the resin cement to cure, we also have transparent fiber posts like these so that the light curing can be achieved completely. So sometimes we also make cast post or a custom made post. So for this we make a direct wax pattern for the post, or we can also make an indirect wax pattern by making an impression. So after making or this cast post is cast using a alloy. Conventionally we use the nickel chromium or the cobalt chromium alloy to cast this, and then after this the casting is seated using a glass ionomer cement. So this is the cast post which is placed, and now you can see the pre-op and the post-op difference. So here you see the cast post into the root canal in an X-ray. So nowadays with modern day dentistry, we also have option of zirconia post, which is formed by CAD/CAM restoration. Just to summarize, so we can have management of teeth which are extensively damaged with a vital, and damaged teeth which are non-vital. So vital teeth are treated by either pins, grooves, or by reinforcing placement of a 3/4 crown, etc. The non-vital teeth are treated by use of post-core surgical crown lengthening or orthodontic extrusion. And when we classify the pose, we have different types of pose ranging from the prefabricated to the custom made pose to the latest zirconia pose. So that completes the chapter today. Thank you.